Welcome. Today we're doing something a little different. We're going to simulate a full consultant-level oral board exam, a viva, as they call it, walking through a classic breast surgery case, from the moment the patient walks in, all the way to the final treatment plan. This is going to be a super high-yield review, whether you're studying for your boards or you just want to really lock in that structured approach to breast cancer. All right, let's jump right in. So here's our roadmap. We're going to follow a candidate through that entire clinical journey. We'll start with the initial consultation, move to the physical exam, then the imaging and the all-important tissue diagnosis, and finally, we'll build out the management plan. We'll be hitting the key decision points and the common pitfalls every step of the way. All right, I'm putting on my examiner's hat now. Let's imagine we're in the exam room. The clock is ticking. Let's set the stage for our candidate. Candidate. A 45-year-old woman presents to your clinic with a new lump in her breast. How do you proceed with the consultation?
Thank you, sir. I would start by introducing myself, making sure the patient is comfortable and that her privacy is respected. From there, I'd move into a thorough and systematic history. My main goal here is twofold. First, to really understand the presenting complaint, and second, to get a clear picture of her overall risk profile.
So, I'd begin by focusing on the lump itself. I need to know when it started, how long it's been there, and if she's noticed any changes in its size. Then, I'd pivot to associated symptoms, especially nipple discharge. The details here are absolutely key. Is it from one breast or both? A single duct or multiple? And what does it look like? Is it bloody, clear, or milky? And really importantly, does it happen on its own, or does she have to squeeze to make it appear? All these little details point us towards very different potential causes.
Good. And what about pain? How does that factor into your thinking?
Of course, I'd ask about any pain, but specifically, I want to know if it's related to her menstrual cycle. Pain that comes and goes with her cycle and is kind of all over is often benign, maybe related to fibrocystic changes. But a constant pain, right in one spot, that's much more concerning. I'd also ask about any skin changes, fever, which might suggest an abscess, or any arm swelling, which is a big red flag for more advanced disease that could be affecting the lymphatics.
Next, I'd systematically build her risk profile. A lot of these questions are really trying to estimate her lifetime exposure to estrogen. So I'll ask about her age when she started her periods, if she's gone through menopause, how many children she's had, and any use of hormone therapies. Then I'd screen for major risk factors, like a personal history of breast cancer or any radiation to her chest, maybe for lymphoma when she was younger. A detailed family history is crucial, and I'm not just asking about breast cancer, but also ovarian, colon, and prostate cancer, which can all be part of hereditary syndromes. Finally, I do a quick review of systems, looking for any signs of metastatic disease, like new bone pain or a nagging cough. Excellent. That's a very comprehensive history. Let's move to the next logical step. How would you perform the physical examination? After getting her permission and with a chaperone present, I'd have the patient sit at a 45-degree angle. The exam always starts with inspection. I'm looking for any asymmetry, skin changes like dimpling, or that classic peau d'orange appearance. I'd have her do 3 maneuvers: arms by her side, arms raised overhead, and then hands pressed onto her hips. These all help to bring out any subtle tethering to the underlying muscle. For palpation, I'd start on the normal, asymptomatic side to get a feel for her baseline tissue. Then I'd carefully examine all 4 quadrants of the affected breast, not forgetting the tail of Spence. If I feel a lump, I'm noting its size, its consistency, and its mobility. Is it fixed to the skin or the chest wall? The exam always finishes with a thorough check of the lymph nodes in the axilla, above the clavicle, and in the neck.
Very thorough, candidate. So you've completed your history and physical exam. You have a clinical suspicion. What are your next steps in the workup?
So the next step is imaging, which is the second part of the triple assessment. That's the combination of the clinical exam, imaging, and a tissue biopsy. Now, for this patient, a 45-year-old with a palpable lump, I would order a diagnostic mammogram. It's really important to make that distinction. A screening mammogram is for women with no symptoms and just uses 2 standard views. A diagnostic mammogram, on the other hand, is specifically for investigating a problem. It will include extra targeted views, like spot compression, to get a much better look at the area we're worried about. The radiologist's findings will be reported using the BI-RADS system, which is basically a universal language for breast imaging. A BI-RADS 1 or 2 is great news, totally benign. BI-RADS 3 means probably benign, and we'd likely just do a follow-up scan in a few months. But the ones that really get your attention are BI-RADS 4 and 5. These mean suspicious and highly suggestive of malignancy, and they are an absolute, non-negotiable indication for a biopsy. And what is the role of ultrasound? Great question.
Along with the mammogram, I would order a breast ultrasound. It's incredibly useful for telling a simple fluid-filled cyst from a solid mass. It's also what we use to guide the needle for the biopsy. But critically, I'd also use ultrasound to take a very close look at the axilla. There are specific features we look for in lymph nodes that are suspicious. A cortex that's thickened, a more round shape instead of the usual kidney bean shape, and the loss of that normal fatty center, or hilum. If I see any of that, I'm going to biopsy that lymph node too.
All right, so you've correlated your clinical findings with the imaging, which comes back highly suspicious, a BI-RADS 4 lesion. What is the definitive step?
Now, before you answer, I want to really emphasize this point. A huge mistake candidates make is just saying biopsy. The pathology report is not just a yes or no for cancer. It is the absolute roadmap that will guide every single decision we make from here on out. So tell me, what specific data points are you looking for on that report, and why are they so important? The definitive step is an ultrasound-guided core needle biopsy. From that pathology report, I need to know several critical things. First, is this cancer invasive, or is it still contained, what we call in situ? I need the specific subtype. Is it ductal or lobular? What's the tumor grade? Then we get to the molecular markers, which are paramount. I need the estrogen and progesterone receptor status, which tells me if hormone therapy will work. I need the HER2 status, which tells me if targeted therapy is an option. And finally, the Ki-67 index gives me a sense of how fast these cancer cells are dividing. All of this information together is what allows us to build a personalized treatment plan.
Let's say the biopsy comes back as ductal carcinoma in situ, or DCIS. Let's make it high grade with comatose. How would you counsel the patient on her surgical management options?
Okay, so for DCIS, I'd explain to her that there are two main surgical paths we can take. The first is breast-conserving surgery, also known as a lumpectomy. The goal here is to remove the DCIS with a clean 2 mm margin of normal tissue around it. This is almost always followed by radiation to the rest of the breast to reduce the risk of it coming back. The other option is a mastectomy. This is usually recommended if the DCIS is in multiple spots, if it's very large compared to her breast size, or if we can't get those clean margins with a lumpectomy. Ultimately, the choice will come down to a combination of these tumor factors and her own personal preferences. You mentioned radiation is almost always given after breast conservation. Are there any exceptions to that rule?
Yes, there are. To really refine that conversation, I can use a tool like the Van Noy's Prognostic Index. It's a scoring system that looks at the DCIS size, the margin width we achieved, and the grade. For patients with a very low score, their risk of recurrence is so low that we can actually discuss the possibility of safely skipping radiation. On the flip side, a very high score might steer the conversation more towards a mastectomy, because the risk of it coming back locally is just too high, even with radiation.
That's an excellent discussion of the local treatment. Let's turn our attention to the axilla. When would you consider doing a sentinel lymph node biopsy for what is technically a non-invasive disease?
That's a crucial point. You're right, pure DCIS is non-invasive. But we do a sentinel lymph node biopsy in certain high-risk situations because there's a higher chance that we'll find a hidden spot of invasive cancer when we look at the final pathology after surgery. The main reasons to do it are if there's a palpable mass, if it's a very high-grade DCIS with that comedonecrosis we talked about, or if it's a very large area of DCIS. And most importantly, we always do a sentinel node biopsy if a mastectomy is the planned surgery for DCIS. Good, and you specifically said when a mastectomy is planned. Why is that timing so critical? Explain the rationale to me, because this is a very common and very serious mistake.
The reason is all about the lymphatic mapping. To do the procedure, we inject a tracer around the tumor, which then travels through the lymphatic channels to the first draining lymph node, the sentinel node. If you do the mastectomy first and remove all the breast tissue, you've completely disrupted those channels. You lose your map. It becomes impossible to accurately find the sentinel node later. That's why it has to be done at the same time as the mastectomy.
Very good. You've walked through this entire case in a very structured, logical, and evidence-based way. That concludes this scenario. As a final thought for everyone watching, remember that at every single step we discussed, the real art of surgery is synthesizing three things: the biology of the tumor, the data from clinical trials, and, most importantly, the individual patient's own values and preferences. Getting that synthesis right is what it's all about.